So the investigations, you have to choose basing upon the suspected etiology. And the most common other thing what you have been telling in the etiology is the hepatitis B and C. So I have to look for the serology of these patients. So look for simple thing, hepatitis surface antigen, HBsAg, anti-HCV. These two are basic to start with. Suppose if the surface antigen is positive, then to know the activity, some other test has to be conducted. Like the antibodies are there against the surface antigen. If it is there, it is immune, already had infection. So on the other hand, if it is an active jaundice is there, surface antigen is positive, and this antibodies against the HBsAg is negative, then we have to see what is the DNA content, hepatitis B, what is the core antigen levels, hepatitis B core antigen, and IgM core antibodies. So, and of course the ALT. So all these things reflects on the activity of the. Suppose if it is positive, then to know whether the activity is there, whether to treat the patient or not, these things are necessary. Otherwise, simple screening, what you need to do is surface antigen for hepatitis B and anti-HCV. Right? The another important thing is endoscopy, upper GI endoscopy, to know whether the patient is having it, viruses, or are there any reasons for the, if the bleed is there, other causes. So endoscopy is another one. So apart from this, what is important is ultrasound examination. Ultrasound is non-invasive, you can do any number of times, it can give good information. So ultrasound utility in cirrhotic patients is, you can see, one is, suppose the fluid, in this patient is good fluid is there, good amount of fluid, there is no problem. So suppose a minimal fluid is there, we can look for whether the fluid is there or not. Second thing is clinically could not make out splenomegaly. So we can assess the size and volume of the spleen. So splenomegaly can be made out. So apart from these, what is important is you have to look for what is the size of the liver. That is normal, increase, or decrease. What is the echogenicity? Increased echogenicity is usually found. And apart from this, we can rule out any space occupying lesions. Whether hepatocellular carcinoma is there, any other things, any cyst or abscess, or any tumors, secondaries. So we can screen for other space occupying lesions. That is one advantage of having an ultrasound. Or even portal vein thrombosis on the splenic vein thrombosis on that. So any obstructive elements you can make out. Collateral seminoma, splenic collaterals. So apart from this, what is important is liver size, echogenicity, and you have to look for the portal vein size. That is very, very important. So clinically, you say whether portal hypertension is there or not. We are not going to attach a manometer and to see the pressure levels. The simplest method is to look for the portal vein by ultrasound. If the portal vein size, if you make out, you can say whether there is a portal hypertension or not. So the normal portal vein size is around 10 millimeters is the diameter and 10 centimeters of water is the average pressure. So if you say in terms of mercury, 7 millimeters of mercury is the normal pressure and it can be around 10 millimeters in the diameter. So you measure the diameter of the portal vein as well as the pressure, so that you can measure out by looking at the size. So the maximum limit of the portal vein is 14 millimeters. If it is more than 14 millimeters, the diameter what I am talking, it indicates a portal hypertension. So by looking at the portal vein, you can say whether the patient is having a portal hypertension or not. So other ancillary things like the splenomegaly, the dilatation of the splenic vein, collaterals at the level of the spleen, presence of ascites, they are all additional contributions to say that the patient is having a portal hypertension or not. So these are the very important things which can be made out by the ultrasound. The another important thing is the analysis of the ascitic fluid, diagnostic aspiration and analysis. So the fluid, we look for the physical characteristics. By basing on the physical characteristics, the appearance, the color, the specific gravity, you can say some conditions can be diagnosed. So in case of cirrhosis, the fluid usually can be clear. Okay, and this can be subjected for the cytology, like a TC, DC. So most of the times, the normal ascitic fluid in cirrhosis doesn't contain much cells. There may be few mesothelial cells. So cytology will be helpful. Suppose we suspect an SBP here, a malignancy here, a tuberculosis peritonitis. So this can be, suppose if it is tuberculosis, there will be leukocytosis with lymphocyte predominance. Suppose there is an SBP is there can be again leukocytosis with predominant polymorphs. More than 250 cells per microliter is indicative of SBP. So in that way, the cytology can be helpful. Or cytology can send for malignant cells that may reveal the malignant cells where there can be malignant ascites. So by looking simply at the cytology, you can say whether it could be simple, likely to be cirrhosis or whether it SBP or tuberculosis or malignancy. These things can be excluded. The other important things are biochemical parameters. One is the protein estimation. So look for the protein. If it is more than 2.5 grams per dl, it indicates exudate. In a cirrhosis, what you expect is the translate. So we should know what is translate and exudate. The parameters for the translate. In cirrhosis, it will be usually a translate. So in a translate, you will have the protein content less than 2.5 grams per dl. LDH less than 200 international units per liter. Sugars usually normal. Cholesterol usually again less than 45 milligrams per cent. So these are all indicative of a translate. Sometimes there can be some false positives or negatives. Totally you cannot depend on these what we call absolute values in the ascites. So for example, in 30% of the patients, the protein content may be more than 2.5 grams. Say for example 3 or 4. Especially in cardiac cirrhosis, the protein content will be high, more than 2.5. So for that we cannot say exudate. Suppose the patient is having a gross malnutrition where the patient is having a hypoproteinemia where the body pool of the protein itself is low. In such cases it can be less than 2, but still it can be an exudate. So there are some false fallacies if you depend only on these absolute values of biochemical parameters of the ascitic fluid. So to overcome this, there is a better criteria, what is called Light's criteria. So in the Light's criteria, what you are supposed to do is you take the ratio of the body fluid to the serum. So you take, say for example, the ascitic fluid protein by serum protein. See the ratio. If it is more than 0.5, it indicates exudate. So less than 0.5 is a translate. For LDH, less than 0.66 is a translate. Okay, so you take the ratio of these very important two parameters, protein and LDH. So less than 0.5, less than 0.66 indicates a translate. Still you are in doubt. Sometimes, as I said, in cardiac cirrhosis, the protein content may be high. So in such cases, what we are supposed to do is take the SAG, serum ascitic fluid albumin gradient. So take the albumin of the serum and the ascitic fluid, subtract it and see what is the difference. If it is more than 1.1 grams per liter, it indicates it is translate, indicates portal hypertension is the cause. Less than that indicates exudate. So these are very important. What are the absolute values? What are the Light's criteria? Still you are in doubt, SAG will be useful to say whether it is translate or exudate. In a case of cirrhosis, what you get is translate. Exudate means there will be some other causes. In a cirrhosis, you should get a translate. Suppose your fluid analysis reveals that this is a case of this patient is having a transudate. It means probably this is a case of cirrhosis. Probably. So same thing can be there in, say, for example, nephrotic syndrome, cardiac failure, కాబట్టి మనం అసైటిక్ ఫ్లూయిడ్ అనాలిసిస్ చేసిన తర్వాత the inference it should come as a transudate. Like your liver enzymes, probably it may be cirrhosis. Acidic fluid analysis again tells probably this may be a case of cirrhosis. Then how we are going to confirm your diagnosis? So I had to do liver biopsy. So especially in the olden days, people used to depend on biopsy only. So there are certain disadvantages. Suppose if the patient is having some bleeding diabetes or hyperglycemia, it may be risky to do the biopsy. How much inflammation is there in the so how much fibrosis is there. So certain things maybe accurately may not be known by doing the biopsy, but the gold standard is said to be the biopsy, where you have to find out three important things to know whether it is a cirrhosis or not. Number one is there should be a liver cell degeneration. Second is there should be a liver cell regeneration. Third thing, there should be a fibrosis. So if all these three are present, it indicates cirrhosis. So nowadays there are some biomedical markers are coming out, and sophisticated scanning methods are also coming in. Like let's say, for example, the elastography is supposed to give better results. There is a FIB-4 score to assess fibrosis by scan itself. Okay, like a double bubble contrast study of the liver. So they're all supposed to be giving a better assessment of the fibrosis. But one disadvantage is in advanced fibrosis, all these things can be useful. So mild scarring, mild fibrosis, most of these things may not be able to pick up it. So the sophisticated scanning methods, they are supposed to pick up the amount of the fibrosis in these cases. So probably there may be an alternative for the biopsy. Established cases, may not be in early cases. Similarly, biological parameters, biological markers like alpha-2 microglobulin, aptoglobin, hyaluronic acid, and propagation peptide 3, and a tissue inhibitor of metalloproteinase 1. So there are like some biological markers are also there by which you can make a diagnosis of cirrhosis. So the conventional teaching is biopsy is the gold standard. Now replacing that, so many things are coming in. Probably this may be more useful in the coming days. Okay, so they're all for theoretical sake how to evaluate the patient. Whenever you are in doubt of the diagnosis, all these investigations are necessary. But clinically, it is quite evident, like what, as I said, total hypertension is there and liver cell failure is there. Clinically, there is sufficient to say that it is a case of cirrhosis. Okay, so having made a diagnosis of cirrhosis, now confirmed the diagnosis, what are the complications of cirrhosis? What are the etiological factors? What are the complications? So you got the etiological factors. Number one is hepatitis B, C, alcohol, non-alcoholic fatty liver disease, autoimmune hepatitis, metabolic and inherited disorders like Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency, cystic fibrosis, cardiac cirrhosis, biliary cirrhosis, primary biliary cirrhosis, secondary biliary cirrhosis. If you don't put any underlying cause, you cannot make out anything, still there is an entity what you call tryptophan. All patients you may not be able to make out the etiology. Some of these cases are kept under cryptogenic. Complications? hepatic encephalopathy, varices bleed and upper GI bleed, hepatorenal syndrome, type 1, type 2, hepatopulmonary syndrome, portal pulmonary hypertension, spontaneous bacterial peritonitis, hepatocellular carcinoma, coagulopathies. So there can be deficiency of vitamin K dependent coagulation factors 2, 7, 9, 10. So this may be deficient, there may be coagulopathy. Okay. Fibrinolysis may be there. Pancytopenia because of the hypersplenism. Thrombocytopenia may be there. It all can cause bleeding, not only the varices. Metabolic complications like which patients can have osteopenia, osteoporosis, osteomalacia. All these things are possible. So there are a lot of complications that are likely. How to manage these cases? Overview. So any treatment that is based on this is not going to improve the survival and prognosis of the patients. So once you said you used one word, decompensated liver disease. So decompensated indicates when there is a chronic liver failure is there, you say decompensated. Most of the times clinically it will be evident by ascites or encephalopathy. Or sometimes GI bleed. If these things are there, you can use the word decompensated. Okay. So the fundamentals of management is the only thing is to improve the quality of the life to a certain extent, but ultimately we may not extend the life of these patients. Once there is a decompensated state, the prognosis will be definitely bad. So it all depends upon underlying cause. If a removable cause is there, if you treat it, still there can be a better prognosis. Otherwise, prognosis will be gloomy. Okay, so the treatment generally aims at one is to give rest to the patient, so there may be some mobilization of the fluid, salt restriction, 100 millimoles per day, water restriction, especially when there is less than 125 millimoles of sodium. Otherwise, usually fluids not necessary to be restricted. So give a rest, salt restriction, fluid whenever necessary, and daily monitor the weight of the patient. You should see that the patient loses weight nearly 1 kg per day. So not remove more than 1 liter of fluid every day, average. So that is one thing. And the diet, other related things is there's so many deficiencies. The anemia may be there, other factors may be deficient, protein may be deficiency. So calcium may be deficient. All these things has to be supplemented. So in a normal patient, there is no need to restriction of the protein. And there is an encephalopathy, it is restricted. Otherwise, they have to give protein also to these patients. Okay. So the diet, salt, bed, rest is really important. So then there is an ascites in this patient. How to treat the ascites is very important. So you give spironolactone is a drug of choice for these patients. So spironolactone is the choice for the reason that it breaks the vicious cycle of ROS system and prevents the secondary hyperaldosteronism. That is the reason why spironolactone is preferred. Okay, it's a weak diuretic, but the purpose of giving this is to break this vicious cycle. So you can start with 25 milligrams, you can go up to 400 maximum. 25 milligram increments can be given, and the maximum can be reached up to 400 milligrams per day. So in addition to that, you can add a loop diuretic in the form of furosemide. So furosemide, you can start with the 20 or 40 milligrams, and you can go up to 160 milligrams. So 400 spironolactone is maximum, and 160 is maximum for the furosemide. Both combination can be given. So once you have reached this 160 and 400, still the patient is not responding properly. It indicates that the ascites is drug resistant or refractory ascites. In such cases, we have to go for the other procedures like repeated large volume paracentesis. So we have to keep it dry. So repeated paracentesis can be done. So when you are taking out 1 liter or 2 liters, it is okay. But when you are removing more than that, you have to supplement it because intravascular volume is low. There can be hypotension, maybe life-threatening. So in such cases, you have to give salt-free human albumin. 6 to 8 grams per 1 liter of removal of fluid is the indication. So usually we will have 20% solution, 100 ml bottles will be there. So every 1.5 to 2 liters you can give 1 bottle of albumin. So we give serum albumin which is salt free and simultaneously we can remove the fluid. That is the best one. Okay. So still sometimes there may be may not be responding. So in such cases, so we have to go for the other things like the tips, transhepatic intrajugular, transjugular intrahepatic, portosystemic stent shunting. So one of the problems with this is hepatic encephalopathy. Portosystemic shunting can cause encephalopathy. The other procedures like the peritoneal caval shunts, peritoneal caval shunts. So there can be a stent can be placed between the peritoneum and the internal jugulars. So the fluid directly drains to the right atrium. So there is one way of removing the fluid. But again, there are complications like sepsis, encephalopathy, portal hypertension, thrombosis. There are complications will be there. So when there is a resistant things, the tips usually being done as a pre-runner for a definite liver transplantation. So ultimately, majority of the people are refusing these patients to take up these as a transitory via media and do tips. So if it is not responding, resistant means the ultimate answer is the liver transplantation. So prognosis. Usually, there are certain parameters to look at the prognosis point of view. We have a child Fuchs classification, where we take the ascites, encephalopathy, serum bilirubin, albumin, and prothrombin with INR. So we got a scoring system for that. Less than 7 indicates better prognosis, A. 7 to 9 is B. Average, more than 9 is C. It is having poor prognosis. Another score is called MELD. Model for end-stage liver disease starts from 9, ends with 39 maximum score. Most of the surgeons will depend on this scale, MELD. For alcoholics specifically, you have what you call Madri score or discriminant function. So 4.6 into difference of prothrombin between the normal and the patient plus bilirubin. If you take this, if it is more than 32, it indicates poor prognosis, where you have to treat these patients with either steroids or endoxyphylline. So at 28 days survival, it's supposed to be better if you treat with these patients when the score is more than 32. This is in alcoholics. And one more scoring system is there, that is called Glasgow alcoholic hepatitis score. So where the people take the age, blooduria, again prothrombin time. So this score again, if it is more than 9 indicates poor prognosis, less than 9 indicates better. So there are different scoring systems, everything says. So some severity definitely versus where is the prognosis. So the lesser side, if it is less than 7 or 9, will be good prognosis. In other cases, it will Overall, if you see, the 5-year survival rate will be once the ascites, the decompensation is there, 10 to 20% of the people will survive up to 5 years. If the patient has got already SBP, encephalopathy, 1 year survival is 50%. 1 year survival is 50%. So it's usually not a reversible disease. And apparently today the patient looks better. Tomorrow he develops another complication. You may predict that he may survive 1 year or 5 years. Suddenly the patient develops tomorrow one complication in GA hemorrhage, he may die and the next day itself. Or hepatorenal syndrome he develops, his life may be cut short. So there is no guarantee that these patients will have a predicted life, but any complication can set in at any time and they can succumb. So these problems will be there with these patients. So that's why these patients require a long-term monitoring, repeated checkups and a regular treatment. What is SBP etiology? Spontaneous bacterial peritonitis. I told you how to diagnose it. So what is the etiological factor?
Transmission of the enteric bacteria into the fluid.
So it is a transmigration of gut bacteria, usually the E. coli. So it is migrating from the gut into the peritoneal cavity. So usually in a patient of hypoalbuminemia, where there is a transudate, so more chances of developing this SBP. Okay. So SBP, E. coli is most common. The other things, sometimes it can be Shigella series of organisms, or even Streptococcus faecalis. Sometimes it can be like. How do you treat it? One is the diagnosis, I told you, the cytology. Is it? Polymers more than 250. Any other way?
Culture of the enteric fluid.
So because there is an organism, you can culture it and see. So that's why you can classify it as a culture positive, a culture negative SBP, cytology positive SBP also. How do you treat it? Third generation cephalosporins can be given, because aminoglycosides can be added, or the piperacillin tazobactam is another alternative. Piptast. Okay. Any prophylaxis against SBP? This is a treatment once the patient has developed. To prevent this, anything can be given. Not penicillin prophylaxis, penicillin doesn't help. Norfloxacin can be given 400 milligrams every day. The other alternative, you can give ciprofloxacin 250 milligrams per day. This has to be given regular basis so that can be prevented. Okay. What is the normal portal vein pressure? When do you say it is portal hypertension? When do you call portal hypertension? And there is a portal vein pressure gradient. Portal vein pressure gradient more than 5 millimeters. It's called as portal hypertension. Okay. So where will be the site of portal hypertension in case of cirrhosis? There is a portal hypertension. Say portal hypertension, portal hypertension. If you see the book, portal hypertension causes, there may be prehepatic pre-sinusoidal, hepatic pre-sinusoidal, hepatic sinusoidal, hepatic post-sinusoidal, post-hepatic. Is it not? So there are different sets, there are different causes can give this portal hypertension. So where is the portal hypertension in case of cirrhosis? It is within the liver, sinusoidal liver. Okay. How do you manage a case of GA bleed? There is varicose bleed. the medical line of management, what is surgical management? So we physicians first we tell,
How do you treat this? Decreases the splenic circulation, which is the vaccine.
you heard about a terlipressin, the role of terlipressin.
Decreases splenic.
So terlipressin is the one IV infusion you can give first. Then of course the other things like somatostatin analogs, actrotide can be given. Okay. Then the endoscopic sclerotherapy you can give, or ligation you can do. So it is common to have this GI bleed. How do you manage a case of encephalopathy?
Lactulose is given.
Only lactulose. Why you want to give lactulose? How much you will give?
With ammonia.
Conversion of ammonia will be prevented by using this disaccharated. The basic concept here. How much you will give? Till the patient develops diarrhea 1 or 2 times per day. That is logical. If you 30 ml or 10 ml, whatever it may be, diarrhea should set in 1 or 2 times per day. Okay. Any specific antibiotic will give for encephalopathy? That specific antibiotics. Rifaximin. Earlier people used to do so many other drugs, neomycin, ampicillin. Now the preferred drug is rifaximin, 550 milligrams twice a day, or 400 milligrams daily. Rifaximin. What is the prophylaxis given for the portal hypertension? Reading the GA manage prophylaxis again. Any beta blockers, propranolol. Propranolol can be given 80 to 160 milligrams per day. The other things, of course, atenolol or sotalol can also be given. Preferred drug is propranolol. What is epidural syndrome?
Renal toxicity. Decreased blood supply to the kidney cause.
These kidneys will be very good in these patients. If anybody needs, you can safely transplant this kidney. It will be very good for the other patients. It's only functional failure. So kidney is okay. You don't get any albuminuria or something like that. You get only creatinine levels will be raised. Okay. So urinary sodium levels you have to see less than 10 millimoles per liter. And osmolality of urine to plasma has to be seen. And creatinine levels has to be estimated. To summarize what we have discussed today, seeing how the patients of cirrhosis presents themselves, symptomatology, and what are the things that you have to inquire in the present history